Welcome to Voices in Value-Based Care. I'm Beth Houck. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. In this program, we're going to explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter at #VoicesInVBC and follow me on Twitter at @BAHouck. On the program today, I talked to Jean Thomas, Vice President and Chief Information Officer for Memorial Hospital at Gulfport in Gulfport, Mississippi. Jean, welcome to the show.
Beth, thank you very much. Pleased to be here. Thank you.
You're so welcome. Could we just start off by learning a little bit about your background? I know that when you and I first met, I was very intrigued by your non-healthcare background that you had to kick off your career, and then, of course, your more recent experience over at Memorial.
Sure. I can try to carve it into two categories. So I used to say that most of my career was not in healthcare. At this point, I really have to say about half of it wasn't. So the first half of my career was largely in the pure technology space, largely when the advent of the PC began to scale, where there were obviously many corporations, many businesses, and the consumerism of having PCs in the home. So I, with a couple of startup companies in the 80s and 90s, all in technology, didn't know anything about healthcare actually, left a company called Microelectronics in about 1999-2000, and got involved with LSU School of Medicine that was building an advanced learning center, and they wanted some technology footprint and some technology prowess in that advanced learning center. I had a relative that worked at LSU School of Medicine, and that's how I got involved in that activity, and met a couple of physicians that wanted to do radiology images on the internet. And this was in the early days, of course. And I thought, wow, that sounds interesting. Educate me. And I had, been involved in some technology companies that went from very small to grew to very large, and figured I understood how to apply technology to certain market segments, et cetera. And I got to tell you, all that played out except for healthcare works differently than other businesses. So I got a lot of lessons learned from that endeavor. But anyway, that's how I got into healthcare. Ran a radiology company, did a little bit in the proteomic space, started working at Gulfport, and actually we've now changed our name to Memorial Hospital and Physician Clinics at Gulfport, because we now own a little over 100 clinics. But anyway, been there at Memorial for about 10 years, and I've gone through multiple iterations of the digitization or electronification of healthcare, if you will.
Well, I look forward to talking to you more about those perspectives that you hinted at. But also, just to give our listeners who may not be from Gulfport, Mississippi, a little lay of the land, can you tell us a little bit about the scope of the health system? And obviously, the name change tells us a little bit too.
Sure, you bet. So traditionally, it was founded in 1946, Memorial Hospital. It was a not-for-profit safety net district hospital. If you were to look at the geography on the southern Gulf Coast of the United States, between the state of Louisiana and Alabama, there's a little sliver of Mississippi, 3 counties that are on the Gulf Coast. And so that's right where Gulfport Memorial Hospital is. And what we've done over time is grown our footprint over the past 7 or 8 years strategically to 101 clinics, multi-specialty, all the way down to family practice. We did that specifically to kind of dominate, if you will, that small region of South Mississippi. We are a 303-bed facility, licensed beds today. We had 445 beds a year ago. We sold our rehab facility and business line, and we sold our behavioral health service line as of December 31 of this last year. So we'll do about 450,000 ambulatory visits this year, about 180,000 outpatient procedures, 60,000, give or take, emergency room visits, and about 17,000 admissions.
Wow, that's quite a scope, and a lot of change in a short period of time. Obviously the program is about value-based care, right? So, and I think that your voice is going to be particularly interesting, not only because of your experience outside of healthcare, which I think always gives somebody the opportunity to look at things in a different way, but also because of the geography that you serve. What are some of the unique parts of serving that geography that you have found?
So, I'll key off of you asked me what's the unique part. So it's kind of unique to me. This is my first not-for-profit experience in business, and it's still kind of interesting after 10 years. But I will tell you what I've learned, and sometimes I'll try to equate this back to my pre-healthcare life when we talked about consumers. I look at patients as consumers, and they're synonymous. That said, if I look at our patient mix, our consumers, about 73 to 75% of our volume is a combination of a Medicare, Medicaid, or uninsured patient. So that's the majority of patients that we see in our health system. And there are numerous facilities around the country that look like us, that take care, that are safety net, not-for-profit hospitals that have either higher or lower amount of patient care in that Medicare, Medicaid, and uninsured population. But it presents a challenge. Socioeconomic, social determinants, there's a lot of challenges there. But kind of on point with your initiative here or your topic is we still are largely fee-for-service, other than the prior requirements of meaningful use and value-based purchasing metrics and various other scores. And now with MACRA, and we are going to be in the MIPS component of MACRA. So value-based care is creeping into our business, our market, our health system, but we're still largely fee-for-service, which is one of the things that I think is important to this topic.
Yeah, I know that I have talked to many people around the country that have really struggled with that. The tsunami change is coming. MACRA certainly introduced it to lots of organizations, but you're still living in a fee-for-service world. I mean, I've talked to you a little bit about this, so I do have a little preview, but tell me a little bit about your perspective on what that means. So you're working in a fee-for-service world. We hear about value-based care and MACRA's pushing, you need to bend the cost curve. What do you think about all that?
So I'll thank you for asking. Let me qualify my answers, and that I want to be a little specific and careful that my perspectives are largely my personal perspectives, and I don't want to necessarily tether those to be the perspectives of Memorial Hospital and physician clinics at Gulfport. So a little bit of disclaimer there, if you will. So from my perspective, and in my prior life, we did a lot of database marketing. We would market to consumers, and that's been going on for decades, where you profile certain customer segmentations of who's likely to be interested in your product, who's likely to buy your product, how often will they buy it. A lot of analysis, I call them well-exercised models and methodologies that have been used in consumer marketing for decades. They're largely applicable to population health, not 100%, but some of the same algorithms and methodologies about predictive analytics, right? We used to predict when is somebody's buying cycle, how often will they buy my product, what's the frequency they'll renew consumables, what's the frequency they'll buy a new car or a new whatever it may be. And so some of those same models you can apply to healthcare, which, to your comment, I think a moment ago, my personal perspective is we have to do more of that to bend the cost curve. So we all know there's not enough money to continue to pay out the needs of the Medicare Trust Fund. Go on Medicare, CMS.gov, look at the trust fund. It's going to run out of money unless through the general funds, taxes are raised. So we get that there's not enough. And the current way we care for patients, personal opinions here, in what I call this treat and release model, which is when something happens, we'll treat it and you get to go back out. But until we get ahead of the curve on how to prevent a chronic condition, other than genetics, can't really necessarily that I know of, I'm not a clinician, so I got to be careful. Can't really prevent that at this point. But how do you prevent a chronic condition? And if you miss the prevention, how do you control someone that has it? And I'll tell you, in my unscientific sampling and talking to physicians, they will tell you in general, one, we can tell people how to prevent a chronic condition. And again, if we miss them, and if they already have it, we can tell them how to control it. And I kind of scratch my head here as a guy, a data guy from the consumer days. So why do we have so many chronic conditions, and why are they so uncontrolled?
It doesn't seem like it goes together, right? I mean, when you put it like that, it is a conundrum that the industry has to deal with is like, okay, if we already know and we know how to fix it, then how do we fix it?
So this is where it can sound not friendly or curse or what have you, but I often say when you talk about population health, where's the population? The population really to bend this cost curve, Beth, and to talk about how we pay for prevention as opposed to the high cost chronic conditions. We got to figure out how do we get the population to be engaged, to be compliant, and when applicable and where applicable, and depending on who's covering their care, there is a portion of healthcare they need to pay for. And again, I'm a consumer as well. We all are family members, loved ones, et cetera. But right now, if you just look at the metrics, it's not going to last. So value-based care has to happen if for no other reason is we cannot continue to pay fee-for-service. The dollars just aren't available. And that's not my analysis. That's many people's analysis. I'm just repeating the data that's already out there.
So how long do you think it's going to take? So this is again a really fundamentally different way of thinking about things. How long is it going to take for us to bend that cost curve?
So I kind of have two answers there. One is I have absolutely no idea. I've speculated, which is not a pretty speculation. The other answer is it won't happen soon enough, whatever the time frame is. And so people say, what do you mean when you say soon enough, Gene? What I mean is there will be some type of, I don't want to say, there'll be some impact to the system, which I think is going to be lack of access that will happen as a result. Because I think you're going to see, in primary care, you hear about the models, the ACO models, other risk-based models, where it's kind of the quarterback. And right now, primary care is under pressure of how do you run primary care clinics to be that coordination of one's health, not in terms of chronic condition, let me treat it, let's be done. How do we prevent it? And so I don't know how long it's going to last, Beth. We know the trust fund's going to run out of money. Last time I looked, I should be careful here. Last time I looked, it was 2025 is when the Medicare trust fund runs out of money. I think politically, the politicians will do what is needed to obviously fund it past that. I think typically they're short-term decisions in my personal opinion. Again, personal opinion. But I think it's going to happen sooner than later. I think we're going to have to figure out, what services get limited, self-limiting as opposed to purposeful, as a result of the model of moving from fee-for-service to value-based care. Really personal perspectives. I got to be really careful here. Sorry to keep going there, but
it's no worry. And part of having a great conversation with you is knowing that you have all of these different personal perspectives. I am going to shift you a tiny bit, though, back to your role in the organization, which is so you're in your role right now, and you have to deal with real life examples of the legs into canoes, right? Fee for service, value-based care, pay for value. Give me some stories. Tell me some times when you've had situations where those two things have really come up in conflict and are in conflict of each other.
Well, good question. Actually, it's sometimes therapeutic to talk about these things because they're not fun when they happen. I'll give you an example, and you're going to know the dates better than I am. I'll generalize. So MACRA was proposed, and then towards the end of the calendar year, it became the final rule, right? And so once it becomes the final rule, then people like myself and my vendors have to scramble. I'll call it the hurry up offense. To try to figure out how do we make sure we have the electronic systems in place, then the workflow, then the processes, then the monitoring, then the remediation of the humans that are learning something new and don't always do things right when you learn something new, particularly when your primary role is to take care of patients. So the frustrating part, I will say, was some of the regulatory requirements that are, I applaud them because they're a move to value as opposed to fee-for-service, but they initiate as a regulatory requirement. And healthcare institutions, we expend significant resources, human and financial resources. So every time I say resources, I'm going to mean both human and financial, on meeting the regulations, which does, in some cases, take away from direct patient care. Now, back to my prior comments, sometimes direct patient care is simply treat and release and not forward-thinking and not preventative, but it is frustrating when there's regulatory requirements that come down, that are passed down at the state, federal, and state level that require us to react very, very quickly. And because so, I'm not sure it accomplishes what they were wanting to accomplish, other than we're getting data collection. And if you do the data collection, you can do better predictive analytics, so long as then you can apply the workflows and the humans to react to the analytics. That's how you get the value. So it's very frustrating, Beth, from that aspect. You know, my role is to put in electronic systems that users use, you know, on the short game to care for patients real time, so they can see everything about a patient, no matter where the patient's venue of care has been, and then to collect enough data to help patients prevent chronic conditions and undesirable lifestyle or disease states that affect them negatively, and then try to get in front of that. It's kind of a polarization, I will tell you, sometimes in conflict.
You know, as most of my listeners here, but may or may not know, I started with the Meaningful Use program in this world. And while it was hard to talk about from the perspective of, yeah, this is very much a regulatory check the box program, the underlying reason for it was to digitize data. And without the digitization of data, you're not going to be able to do all of these innovations. So it was kind of a necessary evil, I think, to kind of kickstart the industry. I am wondering, though, how much are you seeing people using that data? I mean, how much are you as an organization using that in those investments? And what do you see coming in the future?
So I will tell you that I see a lot of people using the data in very meaningful and valuable ways. I will tell you in my experience, which is somewhat limited, Beth, and part of it I want to qualify as my personal opinions and experiences. The other part is we put in about 3.5 years ago, we went live with a significant, what we call a forklift IT transition. So we implemented a brand new electronic medical record across all of our venues of care, went from 3 different, if you will, EMRs between inpatient, ambulatory, and emergency department, went to a full Cerner platform, implemented an enterprise data warehouse, and changed 100% of our enterprise resource planning, finance, supply chain, human capital management. And so we've been pretty internally focused for the past 4 or 5 years. I qualify that to when you say, what are other people doing? So I got a fairly limited view. That said, I've spent a good bit of time on the road over the past 3 years. So there are some people that are using that data. They've got the workflow, the infrastructure, the transformation in place. In our case, we're kind of torn. These are my words, because we have a very high census. We went on diversion last week. So because of our high census, most of the free time to get your clinicians involved in this process and the workflow, and you got to have the clinicians involved. Once you get the data that tells you here's some indicators and here's some things we should look at, and our clinicians are just simply, and our support staff, not just clinicians, but clinicians, we're busy taking care of patients. In this market, in our market with that high Medicare, Medicaid, and uninsured population. So we are using it for things like certain disease states where patients are falling through the cracks, screenings. So we've got a specific program in place where we looked at data, and this is very rudimentary, by the way, in my opinion, but we're finding those patients that are missing their screenings for mammograms, colonoscopies, et cetera, immunizations, and we're asking them to come back in and get those. So let's get in front of it before it happens. Really, really fundamental, but we're using the data in that way. We're starting to analyze. We did a stroke readmission reduction program, data-driven on how can we reduce a readmission of a stroke patient based on the data. So we're starting to do that. I wish we were doing more. We just don't have the time. I know some of my colleagues out there, they're a little more mature than we are, but we've collected the data. So for 3.5 years, we've been populating a data warehouse that allows us to look at those patient populations, other variables in there, and figure out how we're going to move and be successful going from fee-for-service to value.
It sounds like you did what I would call slow down to speed up. So it sounds like your investment in, going to a single system, Cerner system, investing in that enterprise warehouse, I'm sure all of the time and energy that it must have taken to get to that point prevented some other innovations happening, but at the same time, it's so foundational to new things happening. So is that true? Have you been able to really take advantage of all of that investment in a single platform with a single enterprise data warehouse?
So yes and no. I'll give you the yes. Have we been able to work with patients that otherwise we believe would have had a less than ideal outcome because we had the data to get them in the system to prevent something mild or catastrophic? It doesn't always have to be catastrophic from happening. So yes, Beth, in part we have done that. The other part is these are expensive things to put in place, enterprise data warehouse and analytics, and to have the humans, right, to pay for the staff, to use the analytics. Those are expensive things to put in place. And probably I'm going to make a blanket statement here. There's probably a little bit of an overcharacterization. But right now, nobody's paying us to do that. That's where value-based care comes in, right? There is not enough money on the table to say, we're not an ACO, we're not an MSSP, we're not sure that's applicable in our market. Depends on who does that analysis. But right now, no one's paying us for that. Now, I will tell you with a couple of our private commercial payers, they are asking for demographics from us so that when a patient gets discharged, that's one of their patients, one of their covered lives, they work with that patient to try to make sure there's not a readmission. And that's a good thing. First and foremost, what's best for the patient. The problem is they don't pay us, if you will, to keep patients out of the hospital. They pay us fee for service. And I know that could sound really bad to some people, but if you have the right perspective and understanding, they don't pay us to do that. We're all in favor of it, but we got to figure out. And look, here's a tether there. I thought about when I spoke about this podcast. There are right now private payers that are advertising on TV and other methods of media that, hey, Mr. or Mrs. Patient, just do an electronic virtual visit with one of our doctors. And that disintermediates other providers in a market. It's good for the patient. It's just not set up to support that fee-for-service provider in a particular geographic market, in the analog world, not the digital world. If that makes sense.
That's a great example. Yeah, no, it makes tons of sense. And I think we talk to a lot of people. This is not unusual for people to kind of sheepishly admit to the perverse incentives of doing the right thing for the patient, keeping them out of the hospital, yet the financial consequences of doing so that you count on when you're budgeting for an organization, and in particular, in your case, one that has a high Medicare Medicaid population. So this question I have that it sparks may feel very big, but I'll shoot it over to you anyway, which is what do you think can be done? So I think about this a lot, which is here we are again, the two canoe problem. Still have to start to do things. So what are some of the things that we can do that won't hurt us too bad, but at least put us broadly, the country really, on the right path towards a value-based care environment, towards those correct incentives? What are some of the things you think we can do?
So I'll give you some of the things I think we can do. I will tell you, I don't think I'm the right person to ask what's the right combination of things to do, because if I knew that, I'd be in a different position. I don't think anybody knows that, or we would have a better fix for it. But, Beth, look, there's the demonstration initiatives. So, my suggestion, maybe a way to answer your question, I don't know if I have the answer. I have suggestions. Let's take a couple of the best demonstration projects and use those as models to say, great, let's take those, and as opposed to there being more demonstration projects that try more variations thereof, let's take the 1, 2, 3, or 5, whatever, can't be too many, demonstration projects that have proven if we intervene, and we pay for providers to intervene on patients before they become chronic, or if they are, how to manage them to the best lifestyle, which should translate to the lowest cost. If we can figure out models to make that scale, my issue here is not, we know what to do. Providers can tell you we know what to do. Look, if we have the right incentives, if we said to providers and patients, we will, the right incentives, pay you. Let's use that incentive because that happens to work apparently in this country, in many countries. That's not a criticism, it's just a fact. I'm a capitalist, so don't take that wrong. That sounded wrong. I'm a capitalist. But if we incentivized everybody to say, if you will live your lifestyle this way, and if you will care for patients this way, and if we compensate you to, there's no mystery what to do. We have to figure out how do we implement it. This is an issue of how do we make this fit into our current socioeconomic structure, our current reimbursement structure, our current payment structure. Again, this is not difficult to understand what to do. It's difficult to implement, I guess, is maybe what I'm trying to say. So, it's difficult for me to answer that question. I think we should take a couple models, and this is all about scale. I'm sorry, I was going back there. We know what to do when we have a nice little microcosm, a nice little ecosystem that we can get our hands around and we can control it and we can compensate it. But how you do it at scale, I think, is the big issue facing most of us in this country, particularly the young people, who I think ultimately will wind up being either saddled with paying for the baby boomers and then figuring out what kind of health system, what system is left for them that's affordable.
Makes sense. I do think those Medicare demonstration projects, that's an interesting angle. I might want to talk about that on a future podcast, in fact, because that's true. That's what they're aimed at doing, is trying to, none of us have the right answer. None of us have the whole answer, but hopefully by a bunch of different experiments, which is what happens in the private sector, we can land there. We can find it, or at least find some nuggets of interesting findings, and put the incentives in the right place so that we can do the right thing.
Yeah, so maybe some parting thing to what you just said. There's demonstration projects, there's lots of them. I don't think we can implement lots of them. We have to figure out what is the subset of those that look likely to be successful at scale. And that's probably my parting, comment or suggestion is it can't be dozens, it can't be hundreds. It's got to be something we can get our hands around as a healthcare system in this country and figure out how do we make it scale. And you can't scale 20 different things. If you look at other industries that we've all looked at, they wind up consolidating, right? I mean, there's Amazon, there's Facebook, there's Twitter, there's consolidation that always takes place in technology, but particularly in any market. And that's what needs to happen here. Consolidate to a couple models that work and figure out how to do that at scale.
Makes good sense. Gina, I enjoyed the conversation. I always enjoy talking to you. And I enjoy all the different things we've covered. You've given me so many ideas now for any future conversations. So thank you so much for your time.
You bet, Beth. Thank you very much for inviting me. First and foremost, I'm honored and humbled. And, I hope that some of my comments meet the needs of the audience and meet the needs of what you want to accomplish. So thank you very much.
You can learn more about the show on the programs page on healthcarenowradio.com, and lend your voice to the conversation on Twitter at #VoicesInBBC, and be sure to follow me on Twitter at Beth Houck. I'm Beth Houck, bringing you the voices in value-based care you should hear. Until next time, have a great week.